Well, indeed, Kenya's journey of devolution has seen changes in fundamental ways in the governance and service delivery landscape, especially in some sectors. One of those main devolved functions is certainly health. And tonight, we will be having a pulse check on the crucial sector, which is at the heart of many leaders' development agenda. We are joined in studio by the Cabinet Secretary for Health, Nakhumicha Susan Wafula. Thank you so much for joining us this evening, a day to the beginning of the devolution conference tomorrow. Thank you for joining us.
Thank you very much. I'm happy to be here.
Indeed.
To speak to Kenyans on the progress that we have made in health since we came to office and our new focus on universal health coverage.
10 years of devolution. How do you think we fared, especially when we talk about healthcare?
Thank you. Devolution is one of the best things that happened to Kenya. And specifically, it was meant to achieve that services are devolved from the national government to the county governments so that they are able to reach the people at the grassroots. And on matters health, the health services have been developed. And I want to say that within those 10 years, we have seen quite a lot of progress, a lot of improvement in healthcare, especially when it comes to access of services, some very high quality services that would previously be offered only here at national are now available at the county facilities. So on matters healthcare, I think there has been quite some good progress, which is a demonstration of the good collaboration between the national government and the county governments when it comes to service delivery.
All right. Yeah. But there are certainly still concerns coming from different quarters in terms of the gaps and the challenges that we're also still witnessing in the healthcare sector in the country. Just the other day, we did hear President William Ruto talk about health functions, that he says he will not take, claw back on devolution by taking health functions from the counties to the national government. However, there are still concerns that the national government still holds a lot of power in terms of the healthcare sector in the country. Do you agree with this? Is the national government still holding on to more of the functions of the healthcare sector? Does it need to cede some of its power?
Schedule 4 of the Kenya Constitution is very clear on what the functions are in terms of health, what the county governments would do, and what the national government would do. So as we proceed on delivery of UHC, I am aware of Schedule 4, and we are working within the confines of the Constitution of that we are allowed to do. And I want to speak to what today we have done, the launch of assessment of levels of service. That is a national function. But I also want Kenyans to know that that is a critical milestone in terms of UHC delivery. What are we going to do, or what do we anticipate to do with this level of service assessment? Since we came to the office, and the president has been going round. Equally, I have been moving round. We have been receiving requests from wananchi in terms of what needs to be done in healthcare. So we cannot sit aloof and say that we are the national government and therefore we are not bothered. There's a writer who said that a healthy nation is a wealthy nation. Therefore, it is clear to me what we need to do, and that is why today we launched the level of service assessment. Why are we doing this level of service assessment? We want to identify the gaps that do exist, because there are many gaps, and we have received feedback from many Kenyans. We have received requests from many Kenyans. We have gaps on matters of human resource or for health. We have gaps on matters of equipment in health facilities. We have gaps on general infrastructure. We have gaps in equipment. And therefore, we want to do the level of service assessment so that when we say that a facility is a level 2 facility, then it should be able to offer services that are expected to be offered within a level 2 facility.
But Madam CS, isn't it concerning that we've never had that data in place? I mean, 10 years later, still devolution, in place, and we have the county governments who are already, taking part of taking care of the healthcare sector, but still under the national government, which holds some power in terms of ensuring that is quality healthcare across the country. How comes we've never had such data in place?
We have had a census before, but it was just a count of the facilities. But this time round, we are doing a level of service assessment. And I have said is to determine the gaps. But most importantly is that we want to see how prepared are we to deliver UHC, universal health coverage. Remember, we do not want to leave anyone behind in delivering UHC. Therefore, we really need to know what are the levels of services available. Besides identifying the gaps, one of the things that we are going to achieve after determining the levels of service is that we want to group the facilities into what we call a primary network. And this primary network is putting together facilities in a hub and spoke model. So that where you have a hub, then it does majority of the services, but the spokes then are able to speak to the hub in terms of service delivery. But we also want to leverage on technology that a specialist sitting at the hub can offer services to a spoke. That is a lower level facility. A specialist sitting at a level 4 facility can offer services to a patient who is being seen at a level 2 facility through technology. So that is why for me it is important that we carry out this assessment so that we redirect resources. You know, resources are scarce. So we have to redirect them where there'll be maximum impact. So we want to know what are these areas that we really need to invest in and redirect resources to achieve maximum impact. And most importantly, for us to be able to achieve universal health coverage.
And before I leave on that point, I remember you also mentioned a plan to unveil about 100,000 community health promoters. How is this different from what we know as community health volunteers that we've seen working in the counties? What's the difference?
There are many and big differences. One is just even the name alone. You've talked about community health volunteers. There's a problem with volunteering.
Is this usurping the work that the volunteers are doing into what you want the promoters to do?
It is not usurping. It is collaborating and enhancing that which they have been doing. One, they have been volunteering in terms of managing health at the best. But now what we want to do is to promote healthcare. Remember, I have said at the ministry, we are shifting focus from curative services to primary healthcare, which is preventive, promotive, and rehabilitative services. So what is the difference? The volunteers and the community health promoter. For the community health promoters, one is that we have trained them adequately on what the basic things that they'll be looking at in the community. The other thing is that we have kitted them, that they're not going to go into households empty-handed. They're going to go with some form of health commodity items that they can use within the homestead, within which households can use. For example, if a child has been cut by a panga, there's something that they can give to the household to use. If they find there's somebody with fever, an over-the-counter drug that anybody would have walked to a pharmacy and bought, but this now will be available with the community health promoter. And the other thing that we have done with this community health promoter is that we have given them gadgets. Remember, we have said that we are leveraging on technology. So we are giving them gadgets. By the way, the gadgets are locally manufactured. So that is another thing that we have achieved with this community health promoter, that with these gadgets, then we have put an application that we call EKIS, that they're able to pick certain aspects of the household and record them on that gadget. For example, when they go to a household, they have recorded the details of the household. They'll be able to pick out some information. If they find a mother is expectant, then they know that this household, this mother needs to be going for clinics.
So you're saying they're more trained than the community health volunteers who are working within the counties. But is this a program being run under the national government?
This is a collaborative effort. One,
between the national and county governments? And
county governments. Who identified these community health promoters? They have been identified by the county governments.
What was the criteria, by the way, of picking out these promoters?
The criteria of community health promoters is not even one that is just national. It is a global criteria. One, this must be somebody within the community. That because you're going to have to take care of 100 households, you must be living within that community. Number two, this is somebody who is respected within the community. That people will not have a problem sharing with them some personal information. Remember, a community health promoter, when they come to your household, you could share with them, and you expect to share with them some information. So you are respected amongst the community, that the community trusts that the information they give you will remain as confidential information, and they also trust that you should be able to offer some form of solution to them. So these are already leaders within the community. So we have added the training aspect on them so that they're able to carry out the work of a community health promoter, but equally they're already identified within the communities.
Just to change the gears a little bit, let's talk about the issue of, and you've talked about it as well, cartels in your own ministry. You asked Kenyans to pray for you to deal with cartels working within your ministry, derailing the war against graft. Just trying to understand, have the prayers you asked for from Kenyans really worked? And can you be able to unveil the faces of the cabal, the cartels who are working within your ministry?
Prayer is not a one-day affair. Prayer for me, who is a Christian, is a continuous affair, because you continue to experience different things in life and you have to keep praying about it. In terms of cartels, and I remember very well, I think this is when I was talking about NHIF and KEMSA. So specifically for NHIF, what is it that we have been able to achieve? We are still working on the governance structure. But you remember at the same time that I was speaking about cartels, is about hospitals that were claiming for monies from NHIF, which they ought not to have claimed. Now, we are doing facility or level of service assessment. What is it going to do to NHIF? One of the things is that we are going to document the real health facilities and their level of service. So when it comes to, again, now claiming to NHIF, we have nipped it at the bud, that we already know the facilities that we have within the country from this assessment. And we just don't know the facility, but we know what level of service they are able to provide. So if you are to claim that you did surgery, then we indeed know that you have the capacity and capability to do a surgery. So there are many issues around healthcare, but I believe as we go along, Kenyans have been able to see that we're trying to do the right things and doing them right first time. Like NHIF governance, we are still at it.
And where are we in terms of the investigation, by the way, on the NHIF whole fraud scandal?
I have a preliminary report, but I don't believe this is the best place to unveil it. But in the next few days, I'll be unveiling the preliminary report, which has been done by the Kenya Medical Practitioner and Dentist Council, together with the NHIF. Equally, I'll be unveiling what we have done as a ministry. And the, should I call it a reward and punishment system, that we will be saying who continues to operate at their level, who gets maybe demoted to another level, and who do we say for this specific facility, NHIF is not going to work with you, you're fraudulent. That report we are going to release in the next few days.
All right. Yeah. And Madam CS, I think we are out of time, and we have to wind up the conversation. But just very quickly, just to get your quick remarks on this, you had made an order that went viral on social media. Just to get your, your sentiments on that, you received a lot of criticism that came your way on that particular matter in light of the statements you made. Do you feel perhaps that could have been handled a little bit better?
Thank you. President Roosevelt said, it is not the critic that matter. Whoever matters is whoever is on the floor dancing to the dust. And I want to believe that at that moment in time, I was dancing to the dust. You know, if there is a mistake, we have to correct it. I don't want to sit in government and wait for people to do things. If I can do it, why not? But we are working together with my colleagues. Of course, I know my lane is on matters healthcare, but wherever I am, I represent government, and whatever decision that I need to take, I'm not afraid to.
So you would do it again?
So, not that I would do it again.
You do not.
Maybe I would do it better than the way I did it.
All right.
But I will be a responsive citizen and equally a decisive leader.
Indeed.
But allow me just to tell Kenyans in a few words that we are delivering universal health coverage.
Okay.
It has failed previously, not once, not twice, but 3 times. This is the 4th attempt at universal health coverage. We have unpackaged it in 4 main pillars on human resource for health, which we are working on it. We are working on health commodity security. I'm sure you have seen the reforms around KEMSA. Right. We are working on digitization, health management information system, and equally we are working on financing of healthcare. So very soon, and in October 20th, Mashujaa Day, we shall be launching our universal health coverage. I want to invite Kenyans to come and participate, and equally to sit and watch how we revolutionize healthcare in this country.
Indeed. Thank you so much, Madam Health Cabinet Secretary Nakhumicha Susan Wafula, for coming in this morning. And we certainly will be hoping to hear more from your docket during the devolution conference that begins tomorrow in Eldoret in Uasin Gishu County.